Hashimoto's thyroiditis, chronic autoimmune thyroiditis, leading cause of hypothyroidism in iodine-sufficient areas. TPO and TG antibodies present. Goiter may be present. Treatment: levothyroxine. Thyroid hormone regulation, hypothalamic pituitary thyroid axis. TRH from hypothalamus stimulates TSH release from anterior pituitary. Negative feedback by T3, T4 on hypothalamus and pituitary. Hyperthyroidism. Common causes: Graves' disease, toxic multinodular goiter, thyroiditis. Symptoms: weight loss, heat intolerance, palpitations, anxiety, tremor, exophthalmos, Graves' disease. Hypothyroidism. Common causes: Hashimoto's thyroiditis, iodine deficiency, post-thyroidectomy, medications. Symptoms: fatigue, weight gain, cold intolerance, constipation, dry skin, bradycardia. Iodine deficiency, leading cause of preventable intellectual disability worldwide. Causes goiter, hypothyroidism. Prevention: iodized salt. Excess iodine can paradoxically cause hypothyroidism. Wolff-Chaikoff effect. Thyroid dysfunction in lithium. Therapy. Lithium can cause hypothyroidism or rarely hyperthyroidism. Inhibits thyroid hormone release and synthesis. Regular thyroid function monitoring required in patients on lithium. Marine-Lenhart syndrome, coexistence of Graves' disease and functioning thyroid nodules. Presence as Graves' with focal areas of increased uptake on scan. Treatment may require both antithyroid drugs and surgery, RAI. Thyroid function tests, TSH, most sensitive. Free T4, free T3. TPO antibodies for autoimmune thyroid disease. Thyroglobulin for monitoring thyroid cancer. TRAB for Graves' disease diagnosis. Myxedema coma, severe hypothyroidism. Presents with altered mental status, hypothermia, bradycardia, hyponatremia. Precipitated by infection, drugs, cold exposure. Treatment: IV levothyroxine, supportive care. Pendred syndrome, genetic disorder causing congenital hypothyroidism and sensory neural hearing loss. Defect in pendrin protein, chloride iodide transporter. Associated with thyroid goiter. Postpartum thyroiditis, autoimmune thyroiditis occurring within a year after delivery. Triphasic, hyperthyroid, hypothyroid recovery. 20% risk of permanent hypothyroidism. Monitor thyroid function postpartum. Radioactive iodine therapy. Used in Graves' disease, toxic nodules, thyroid cancer. I-131 destroys functioning thyroid tissue. Precautions: avoid pregnancy, limit close contact post-treatment. May cause hypothyroidism. Radioiodine uptake and scan evaluates functional status of thyroid tissue. Used in differentiated thyroid cancer, follow-up, diagnosing hyperthyroidism etiology, low uptake in thyroiditis, high in Graves. Rydell's thyroiditis, rare fibrotic disorder of thyroid, hard fixed goiter mimicking cancer, associated with other fibrosing disorders, IG4-related disease. Treatment: surgery for compression, steroids, tamoxifen. Subacute thyroiditis, viral etiology, self-limiting. Phases: thyrotoxic, hypothyroid, recovery. Presents with neck pain, fever, high ESR. Treatment: NSAIDs, beta blockers, rarely steroids. Subclinical hypothyroidism, elevated TSH, normal free T4. Controversy in treatment, especially in elderly. Consider treatment if TSH10-MyUL symptoms present or high TPO antibodies. T3, T4 actions: increase basal metabolic rate, heart rate, cardiac output, promote growth and development, enhance CNS function, regulate bone turnover. T3 is more potent, mostly derived from T4 deiodination. Thyroid hormone metabolism: T4 to T3 conversion by deiodinases. Type 1, liver, kidney. Type 2, brain, pituitary. Type 3, placenta, brain. Altered in illness, affecting thyroid function interpretation. Thyroglobulin. Monitoring, tumor marker for differentiated thyroid cancer post-thyroidectomy. ensure absence of interfering antibodies. Rise suggests recurrence, combined with imaging for surveillance. Thyroglossal duct cyst, congenital midline neck mass, moves with swallowing, yes tongue protrusion. Treatment, cyst-trunk procedure, cyst excision with central hyoid bone segment. Thyroid dysfunction and Down syndrome, increased risk of thyroid disorders. Congenital hypothyroidism more common. Annual thyroid function screening recommended throughout life. Thyroid anatomy, butterfly-shaped gland, 2 lobes connected by isthmus. Located anterior to trachea, deep to sternothyroid and sternohyoid muscles. Weighs 15 to 20 grams. Supplied by superior and inferior thyroid arteries. Thyroid cancer staging, TNM system. Factors, age, tumor size, extrathyroidal extension, lymph node metastasis, distant metastasis. Guides treatment and prognosis. Different systems for differentiated versus medullary cancer. Thyroid cancer types. Papillary, most common, good prognosis. Follicular. Medullary, from C cells associated with men too. Anaplastic, rare, aggressive. Treatment, surgery, plus radioiodine ablation. Thyroid eye disease, associated with Graves' disease, can occur in euthyroid hypothyroid states. Features, proptosis, periorbital edema, extraocular muscle dysfunction. Treatment, lubricants, steroids, orbital decompression. Thyroid ultrasound-guided FNA increases accuracy of sampling. Real-time visualization ensures correct nodule targeting. Reduces non-diagnostic samples, essential skill for endocrinologists and radiologists. Thyroid, hemiogenesis, congenital absence of one thyroid lobe, usually left. Often asymptomatic, discovered incidentally. Increased risk of thyroid disorders in the remaining lobe. Regular monitoring advised. Thyroid histology, follicular cells, principal cells produce T3, T4. Parafollicular C cells produce calcitonin, follicles filled with colloid, thyroglobulin, cuboidal epithelium lines follicles. Thyroid hormone replacement, levothyroxine, T4, standard treatment. Some patients benefit from T3 addition. Adjust dose based on TSH symptoms. Take on empty stomach, separate from interfering medications. Thyroid hormone resistance. Reduced tissue responsiveness to thyroid hormones, usually due to THRB gene mutations. Presence with high T3, T4, normal high TSH. Treatment challenging, often symptom-based. Thyroid hormone synthesis, iodide trapping, oxidation, organification of tyrosine residues, coupling of iodotyrosenes, MIT, DIT to form T3, T4, regulated by TSH, stored in colloid as thyroglobulin. Thyroid hormone transport, T3, T4 bound to TBG, transthyretin, albumin. Only free hormone is active. Conditions affecting binding proteins, e.g. pregnancy, liver disease, can alter total hormone levels. Thyroid function in pregnancy, increased TBG, HCG stimulation of TSH receptor, normal TSH lower in pregnancy, crucial for fetal neurodevelopment. Screen high-risk women for hypothyroidism in early pregnancy. Thyroid lobectomy, removal of one thyroid lobe. Indications, solitary nodules, follicular neoplasms. Advantages, lower risk of hypothyroidism, unilateral RLN risk. May require completion thyroidectomy if cancer found. Thyroid nodule management, most are benign. Evaluate with ultrasound FNA if indicated. Follow-up based on U.S. characteristics and FNA results. Consider surgery for suspicious or large symptomatic nodules. Thyroid nodules. Prevalence increases with age. Most are benign. Evaluate with ultrasound. Fine needle aspiration. Risk factors for malignancy. Rapid growth, hard consistency, fixation, lymphadenopathy. Thyroid storm, life-threatening thyrotoxicosis, precipitated by stress, surgery, infection. Features, hyperpyrexia, tachycardia, altered mental status. Treatment, beta blockers, anti-thyroid drugs, steroids, cooling. Thyroid ultrasound, first-line imaging for thyroid nodules. Evaluates size, composition, solid, cystic, echogenicity, margins, calcifications, vascularity, TI-RAD system for risk stratification. Thyroiditis, classification, acute, suppurative, subacute, de Quervain's, chronic lymphocytic, Hashimoto's, chronic fibrosing, Rydell's. Each has distinct etiology, presentation, and management. Total thyroidectomy. Indications include large goiters, thyroid cancer, refractory Graves. Complications: recurrent laryngeal nerve injury, hypoparathyroidism. Post-op calcium monitoring crucial. Toxic multinodular goiter. Hyperfunctioning nodules causing hyperthyroidism, often in iodine-deficient areas. Presents with compressive symptoms, hyperthyroid signs. Treatment: surgery or radioiodine. Thyrotropin-releasing hormone, TRH. Test used to differentiate primary from secondary, tertiary hypothyroidism. TRH injection should increase TSH in primary hypothyroidism, blunted in secondary, tertiary. TSH-secreting pituitary adenoma, rare cause of hyperthyroidism. Presence with elevated T3 and T4 and inappropriately normal, high TSH. Diagnosis: MRI pituitary TRH stimulation test. Treatment: transsphenoidal surgery. Amiodarone-induced thyroid dysfunction can cause both hyper and hypothyroidism. Type 1, iodine-induced, versus Type 2, destructive thyroiditis, hyperthyroidism. Regular thyroid function monitoring required. Propylthiouracil in pregnancy. Preferred antithyroid drug in first trimester due to lower risk of embryopathy compared to methimazole. Switch to methimazole after first trimester due to risk of PTU-induced hepatotoxicity. Autoimmune polyglandular syndrome type 2, association of autoimmune thyroid disease, usually Hashimoto's, with Addison's disease and/or type 1 diabetes. Screen for other autoimmune conditions in thyroid patients. Congenital hypothyroidism, most common preventable cause of intellectual disability. Newborn screening crucial. Causes: thyroid dysgenesis, dyshormonogenesis. Early levothyroxine treatment essential for normal development. Fine needle aspiration, FNA, gold standard for evaluating thyroid nodules. Bethesda system for reporting cytopathology. Categories IVI, guiding management from benign to malignant. Graves' disease, autoimmune hyperthyroidism. TRAB stimulates TSH receptor. Classic triad, hyperthyroidism, diffuse goiter, ophthalmopathy. Treatment: antithyroid drugs, radioiodine ablation, surgery.